Good morning. On behalf of the Ohio Hospital Association, welcome to this special event to highlight OHA's community partnership to combat sepsis. I'm pleased to report that in just 18 months of launching our statewide sepsis initiative in June of 2015, Ohio hospitals have achieved a 13.4% reduction in sepsis mortality, resulting in an estimated 1,486 lives saved. Our progress is summarized in a recent report released this month highlighting OHA's and Ohio hospitals' efforts. OHA has built a remarkable legacy as serving as the united voice of Ohio hospitals and health systems. Today, we represent Ohio's 220 hospitals and 13 health systems by advocating for them with Ohio policymakers, providing resources through patient safety and quality improvement programs, leading emergency preparedness, and developing economic and policy solutions to sustain and grow access to health care for all Ohioans. Over the years, our quality initiatives have focused on reducing infant mortality, eliminating ventilator-associated pneumonia, promoting population health programs, and preparing for emergencies such as Ebola. In 2015, the OHA identified sepsis as a quality improvement focus area and set a goal to reduce sepsis mortality in Ohio by 30% by 2018. Sepsis is the body's overwhelming and life-threatening response to infection, which can lead to tissue damage, organ failure, and death. Most people recognize a heart attack or a stroke as a medical emergency. In the past, a heart attack or a stroke may have been a death sentence, but thanks to well-coordinated care by emergency health providers and efforts to educate the public on the signs of a stroke or heart attack, hundreds of thousands of lives have been saved. Sepsis is a medical emergency that quietly kills as many Americans every year as stroke and heart attack. In 2016, Ohio hospitals treated more than 38,000 patients for severe sepsis or septic shock. Of those, 7,380 died. Sepsis is the most expensive condition to treat in the entire U.S. healthcare system, accounting for $24 billion in annual costs. Sepsis costs the Ohio healthcare system over $600 million every year, with the case of severe sepsis with septic shock reaching $100,000. In 2016, CDC declared sepsis a medical emergency and emphasized the importance of timing to stop the progression, meaning treating sepsis as an emergency and getting treatment immediately. Last year, OHA kicked off a statewide hospital collaboration to promote the science of sepsis. OHA SOS is an education campaign for community caregivers and first responders to recognize the science of sepsis. Today, OHA is convening one of our largest statewide quality collaboratives in our entire history. We're working with 124 member hospitals to promote early recognition and appropriate treatment. But we have a lot of work to do. Only 1% of adults know the signs of sepsis. As the vast majority of patients with sepsis arrive at the emergency department with the condition already progressing, we must work with our community partners to build awareness. EMS, nursing homes, home health, caregivers, the community at large are all vital to educating our communities. I want to thank our partners, the Sepsis Alliance and Leading Age Ohio, for their leadership on this effort. I also want to thank our member, Fairfield Medical Center, and especially Rick Cochran and Denise Bauer for being here today. Today's event will provide you with information about our campaign with presentations from OHA's quality leadership, as well as two community partners, the Sepsis Alliance and Leading Age Ohio. Please join me in welcoming OHA's Vice President of Quality Programs, James Giuliano, who will provide an update on OHA's quality efforts and introduce our panel. Thank you.
Thank you, Mike. According to the latest survey published by Sepsis Alliance nationally, only 58% of Americans have ever heard the word sepsis. And of that 58%, most individuals don't really know what the word means. The goal of today is to change that statistic and to improve it. So what exactly is sepsis? Sepsis is your body's toxic response to an infection. When you have an infection, your body fights very hard through its immune system to fight that infection. Sometimes it requires the help of medications such as antibiotics, antifungals, or antiviral medications. And this is sepsis. Most of the time, sepsis occurs because of an infection that's been acquired in everyday life. Most people don't realize this. In fact, 80% of sepsis cases that present to a hospital already have developed. So this is not the result, typically, of a hospital procedure or a hospital complication. In order to recognize sepsis early, it's very important that we understand and identify the signs of sepsis. And for this, we would like to refer to the Sepsis Alliance mnemonic of sepsis, where we will talk about what those signs are. S stands for shivering, fever, or very cold. E stands for extreme pain or generalized discomfort. P stands for pallor, pale skin, or discolored skin. S, again, stands for sleepiness or difficult to rouse. I stands for the feeling that I feel like I might die. And S, again, stands for shortness of breath. At first glance, these symptoms could appear to be very vague and seem like flu-like symptoms. That combination of symptoms, coupled with either a suspected or a confirmed infection, could be the sign of a medical emergency that we call sepsis. If you are concerned about this, it's very important that you receive care from a healthcare provider or by calling 911 to activate the emergency medical system. Just like with strokes and with heart attacks, timely treatment is so crucial for survival. In fact, you may not know that for every hour of delay in treatment, the chances of survival decreases by 8%. Therefore, today we would like to focus upon community awareness on the signs of sepsis. We're very pleased today to have joining me today here at the Ohio Hospital Association a couple who has lived through sepsis. A survivor, Rick Cochran, and his wife, Denise Bauer. We're going to start with talking with Denise Bauer. Denise serves as Chief Executive Officer at Fair Hope Hospice, located in Lancaster, Ohio. She's also a registered nurse. Rick and Denise, welcome today.
Thank you.
Thank you.
Denise, I'll start with you. If you could tell us your story. I mean, you were the first to recognize this and to ask for help. Tell us what happened, please.
Well, actually, I was at a meeting out of town and about an hour from our home, and the meeting ended at 8 at night, and so I went back to my hotel room because I was spending the night because the meeting also started at 8 in the morning, and I didn't want to, be in rush hour traffic. So I went to my hotel room, and as I always do, I call my husband to see how he's doing, say goodnight. And when I called him, it was a little unusual. He answered the phone, but he was in pain. He kept saying, "Ouch, oh, that really hurts." And I'm like, "Honey, what's wrong?" I said, Did you hurt yourself at work?" Because he had worked that day. And he said, "No, I didn't." But I said, "Did you lift something?" Because he was complaining of pain in his groin area. And I saw him that morning before I left for work, and he was fine. So I just thought, this doesn't sound right. I said, "Do you want me to come home?" He says, No, don't come home. Just stay at your meeting. I'm fine. But in between, he kept just saying, "Ouch," like it was almost a wincing pain, and it was something that he'd never had before. And as a nurse, of course, I try to do a phone assessment. I'm like, "Okay, tell me where it hurts." And it was like localized in his groin area. And it was intermittent, but I said, "Is it worse when you stand, when you sit?" So I was trying to figure out why he was having this pain. So I said, "Well, why don't you sit in your chair and put your feet up?" And so he has a recliner that he enjoys. So he sat in his recliner, and he still kept saying, "This really hurts, ouch," And so it was almost just overwhelming him. He really didn't even want to talk. So I said, "Well," he says, "Well, you just stay at your meeting. I'm going to be fine." I said, "Well, I just had a gut feeling that I needed to stay on the phone with him because I was concerned." So I said, "Well, I'm going to lay here on the bed. I'm going to talk to you. Let's don't hang up. Let's just talk for a little bit." So as we were talking, I was just asking him about his day and things. And then all of a sudden he said something really unusual, and it sounded like he was confused. It was like he was talking about his work. "Well, I need to put that up on that shelf." It just was very unusual, very confused. And I tried to redirect him and ask him questions about what he was talking about, but it was obvious to me at that point he was a little confused. So knowing that that's not him, I said, "I'm coming home, and I'm going to I'm going to call for help. So, I'm up about an hour away, and so I didn't even check out of the hotel. Ran to the car, calling 911. Going around 270, 70 miles an hour, 911 on the phone. And anyways, I was able to dispatch someone to go to our home. And of course, he couldn't get out of the chair at that point, or I didn't know if he could. So I just gave him the code to get in the garage, and they went in quickly, and they were assessing him. And they were saying, now, I had told the dispatcher, all the information that I had, and it was, I didn't realize that they would even talk to me on the phone. And I, really don't remember if they called me. They called me. And as I was talking to them, they said, well, ma'am, we've assessed him. His vital signs are stable. He seems to be alert and oriented now. And I said, sir, he was very confused. That's not my husband. He's like Mr. Control Freak. He's never confused, and he's always in control. And I said, that's just not him. I said, there's something wrong with him. I know it. He's had pain, and he really wasn't complaining about the pain then, but the confusion, was, just totally not appropriate for him.
And so, Denise, excuse me, did you know the signs and symptoms of sepsis prior to this?
I've worked with patients in intensive care units in the past. So, but what I was really thinking is he was having a stroke. Because, but the pain didn't really go along with it. That's what confused me, because he was having pain. But in my mind, I was thinking stroke. And my daughter's a nurse. I was talking to her on the freeway on the way, and his daughter. And so really, I just didn't know what was going on. I knew something neurological had happened because he was confused. But my gut was thinking maybe he had a stroke, but he was conversing. So I didn't really know. But I did know the signs, symptoms of sepsis, I guess, if I think back. But that wasn't the first thing on my mind, really. But it was just that change, and just, I knew that there was something desperately wrong for him to have that confusion and that pain. And so then the squad, they checked him, they said, he's fine, ma'am. And a layperson might have said, okay, this is what I want to impress on people. If a squad comes to your home, they say, hey, he's okay. Most people are going to say, okay.
Well, in all honesty, I was out of it because I don't even remember half of it.
You didn't remember it. But the squad says, he's alert and oriented now, ma'am. His vitals are stable. We can't really see anything wrong with him. I said, no. I was just insistent in my gut. I said, no, there's something wrong with him. He was having pain, and I said he was confused. I said, it's not him. So then something came over me. I said, have him stand up. Just ask him to stand up for me. And as soon as he stood up, something must have happened, and I never found out from the squad, but my guess is he decompensated. And they're like, okay, ma'am, okay, we're going to transport him. And so at that point, I stayed on the phone as long as I could. Of course, by the time I got close to my house, I could see the squad lights in my rearview mirror. So then I turned and went to Fairfield Medical Center to meet him in the emergency room at that point.
Yes. So that persistence and that sense that something was not quite right, even from a distance, is what led you to do this. And
right.
Well, thank you very much for sharing that perspective. Joining us also today, we're fortunate to have Rick's care team from Fairfield Medical Center, who took care of him during the course of his stay. And at first, we would like to go to Dr. Karen Miller. Dr. Miller is an emergency room physician at Fairfield Medical Center in Lancaster, Ohio. Dr. Miller, can you tell us a little bit about the handoff that occurred between the emergency medical squad and the emergency department staff?
Okay. So typically the squad brings in the patient. They usually give the report to the nurse, and then the nurses usually come to us, say, hey, this patient's really sick, I need you to come and take a look. And sometimes the squad personnel recognizes the signs of sepsis. However, in this case, I'm not sure that they were clear on what was going on, but they knew something was wrong based on your concerns and the fact that when you asked them to stand up, something happened. And so the nurse came to me, they said, I have a patient I need you to come see. And actually the nurse said, I think he might be possibly septic. So I went back to the room, and yes, his blood pressure was low. He was a little tachycardic. He was intermittently confused during his stay in the ER. And initially there was a wound on your leg. I believe it was your right leg. Mm-hmm. But there was also other symptoms and physical exam findings. So we go through often a large workup when we want to make sure we're not missing other sources where the infection could be. Cellulitis is a possible source of sepsis, but could there be a potential other problem going on as well? So we do lots of blood work and scans, and we try to administer fluids. We have at our hospital now, thanks to the work of our intensivist with the ED, we have a sepsis alert program. So when we are concerned about sepsis, we alert, and it goes through a pager-wide system, so that way the patient can be monitored closely and different vital signs will be repeated, and repeat lactic acids can be ordered at the 6-hour mark. And we initiate the fluid boluses, and when the blood pressure may or may not respond to the given fluid bolus that we need to give, we have to initiate other courses of treatment. And I believe in your case, unfortunately, we had to put in the central line and start vasopressors to keep the blood pressure elevated. So it was a true team effort between the squad and you, Denise, and the nurse. And
Well, one thing I remember in the ER that you did, and that I was really impressed of, especially having nursing, my background, is that you called the other physicians. So it's the stroke, the sepsis alert, which I didn't realize that's what it was. But I was so impressed that it's like you didn't think I can just do this on my own. I'm going to bring in the experts that deal with this every day, and that I think really helped a lot. Not that you didn't know what to do, but that really impressed me that you brought the other physicians, and from the get-go you were getting that other expertise, and it was really a huge team approach, and I appreciate that.
sure, yeah,
Well, thank
absolutely.
you both, and it sounds like quite a mobilization. And one of the things that we like to impress upon the care of sepsis is that it does take a village. And so next we move to the inpatient stay after the emergency department, and joining us today is Dr. Jared Bruce, who is an intensivist at Fairfield Medical Center. And Dr. Bruce, could you tell us a little bit about the challenges that occurred on the inpatient side? Now, Rick is out of the emergency department and in an intensive care unit, in a critical care unit.
Yeah, with sepsis being a time-sensitive diagnosis, meaning, as we've said, that time is what matters and time can save lives with therapy, it's that handoff point that can sometimes have where the care slows down, but because of the sepsis alert and all of the ICU nurses, the ED nurses, that transition has really improved, so it's seamless. So the care that's being delivered emergently in the ED is then transitioned into the ICU.
So there's no extra delays or
No, and I think that streamlining of that process is what and making that into a process is what has really helped that, because inevitably there can be delays in that sometimes if you're not recognizing it, and as we have started to recognize sepsis again as such a time-sensitive problem. What we dealt with in the ICU was the end organ results of severe sepsis and septic shock. If something could stop working, it did. From a lung standpoint, kidneys, heart, and often we talk about acute kidney injury being part of sepsis, which we saw. We dealt with respiratory failure, needing to be intubated, placed on a ventilator, and having a tracheostomy because we were unable to get off the ventilator. But these are the outcomes of severe sepsis, but it is the survival that by doing it the right way early, that yes, you may still develop these problems, but you can get through them. Whereas the failure to recognize, the failure to act soon is where we realize that sometimes those problems can get too far gone, and then you aren't able to get out of that spiral, aren't able to get out of that place where the organs have failed too much.
That sounds like a lot of challenges. What would you say was the biggest challenge in this situation? I mean, you mentioned multi-system organ failure. You mentioned if something could go wrong, it did. As an intensivist, your perspective?
His wife was difficult to deal with.
His family's fine.
From a respiratory standpoint, I think, so we developed ARDS, which is a profound respiratory failure where an infection on his leg ended up leading to downstream effects where his lungs could not oxygenate. He just could not get oxygen into his body. And it was a very tenuous time point trying to get through those first 24 to 48 hours where we really were having the most difficulty oxygenating him.
Yes. Well, thank you very much for sharing that perspective. Now, during the inpatient stay, Rick also received pastoral care services from Chaplain Greg Schmalfelt, who's joining us today. Chaplain, would you please share with us some of the challenges of providing spiritual care to someone with sepsis?
Certainly. Well, one of the perspectives that I'd share, especially in his situation, often when I come in and visit with patients that are in kind of mortal danger, oftentimes folks look to their faith for a sense of strength and hope and healing. And once I met Rick and Denise and their families and did an assessment, both emotional and spiritual care, we immediately then went to prayer, seeing that as a vital part of who they are, and praying on Rick's behalf for his divine healing, for comfort and peace for the family, and I always pray for wisdom for the staff. And so we did that, really gave a sense of assurance and affirmation for the family there. Continued doing that throughout his hospital stay, but also on the side of the emotion. As we've just been talking, there's so many pieces to thrusting family and patients into these urgent matters, and it really creates a lot of anxiety. So maybe part of my role is to bring a little bit of sense of peace and assurance. So often I come and visit and try to let a little air out, try to be able to convey that sense of peaceful presence and assurance and just encouragement, because it's times like those that we cannot see the future, and yet we trust that what we see in front of us, the medical team, and that there's a divine part of this. So we were very excited to join together on all those holistic aspects and support Rick and his family.
Thank you. Thank you. And so a very comprehensive, holistic approach from the entire care team, from the emergency department on the inpatient side, spiritual care as well. You know, at this point, it's important for us to go to Rick, our survivor. And Rick, we'd like to hear your story. I mean, we're hearing that this began from some type of an injury to your foot.
Yeah.
What do you remember, Rick?
Well, I remember talking to my wife on the phone, and then the next thing I remembered from that point was the EMS in my house, and I'm wondering, what are these people doing in my house? And I'm really confused. I can hear in the background, I can hear her voice on the phone, and I don't even remember even seeing anybody. And I remember them saying, oh yeah, his vitals are fine, he's alert and oriented, and I'm thinking to myself, what? And then I remember her saying, stand him up. And they stood me up, and I just remember saying to myself or out loud or whatever, hey guys, this ain't gonna happen. And then that's basically what I forgot for the next 2 weeks. I've heard from other people that I said some stuff and that kind of thing, and I was in and out of consciousness or whatever during that 2 weeks, or especially when I got to the emergency room. I don't really recall it. I mean, there's some like dreamlike states of things that I had, but really don't recall a whole lot during that 2 week period that I was. And I also was in a paralytic coma induced. And that was kind of weird in itself. I would say though that my biggest challenges is when I finally did wake up. And you wake up and I'm laying there and I'm looking around and I'm going, where am I at? What's going on? What has happened? And then I see these people all around me that I don't really know, a whole lot of them. And I see part of my family there, and I feel tightness in my throat. And I'm wondering what's going on. And I can't talk now. I can't communicate. And they're telling me, oh, you got a trach in, you got all this feeding tube, you've been through it a lot, da 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 da. And it's just like, it was overwhelming. And to the point that they said, all right, and I was trying to communicate with everybody because I wanted questions answered, because like everybody said, I am kind of a control freak when it comes to things, and not knowing what happened to me for 2 weeks really bugs me. And it still does to some point. So they gave me a dry erase board, and I remember trying to write questions out, and nobody could read my writing because my muscles from laying in bed for 2 weeks were kind of atrophied. And so I couldn't coordinate my hand-eye coordination stuff. And so it was very difficult to communicate that way. And then I thought, oh, I'll use my cell phone and I'll text everybody. So I got my cell phone and I'm here going, and then I look at the screen and it's saying QRTPF. My mind's thinking and knowing what's going on, but I can't communicate. So because I'm very strong-willed and stubborn and that kind of stuff, I ended up talking around my trach, which everybody was just kind of freaked out about. But I guess it was my will to communicate, my will to get up and get out of there, because I've never really been a hospital patient in my life. I mean, I come from a medical family. Everybody that's in my family is in the medical field, it seems like. But myself personally, I've never been involved with it. But that feeling of helplessness, waking up and not being able to communicate, not knowing what happened in my life, is the hardest thing to ever do.
Yeah, and you're describing a lot of very frustrating and difficult moments. What gave you the most hope during all of this?
Right here. She was encouraging me from day one. I knew I was in good hands. I knew that any decision that was going to be made medically, it was going to be a correct decision because of her. I have all the faith in the world in her, and then after I met the hospital staff and that kind of stuff that had been taking care of me, and their compassion and their caringness, and anything that I needed, they were on and jumping on it. This man right here, he, and I do get emotional about this now because I didn't at the time. I just woke up out of my coma, and this gentleman comes in and says, "You probably don't remember me," and I'm looking at him going, "Yeah, I don't have any idea who you are." And he goes, "Well, I was in when you first came in here, and we worked through some things." And all the whole time he's kind of holding my hand and patting my hand like this, you know, and I can see that he's being emotional about it too, because I really think he didn't think I was going to be there when he came back, because you know he had been off for a couple weeks for as far as his rotation at the hospital, and then he just kind of looked at me and says, "You mind if I give you a hug?" And I'm here going, "Okay, fine." But then after I found out everything that he did to save my life, and I understand now the emotion, and I give him a lot of credit for everything that helped me get through all this. But more than anything else, it was his compassion, because I could see a tear coming to his eye when he was giving me a hug.
Yes.
Because he felt so deeply about trying to help me, get by all this. And so, to him and all the staff that helped me out, I mean, there was a couple aides that gave me baths and stuff like that I would just, they can do anything they want to me, and I'll let them do it. They were just that good.
Well, what an amazing story, and really team effort and success, but a road to survivorship. Rick, what would you say to the community members who may not have ever heard of sepsis before? What message would you send to them?
Don't take chances. If you get a small little nick or anything like that, make sure you get it cleaned out. Make sure you get the right antibiotics or something like that. If it starts to fester or something like that, take care of it. Don't wait around and see. So many of us men, especially, we get a little symptom and say, "Oh, we're okay. We can just get by this. We'll fight through it." And I'm just as guilty as everybody else. We can't do that. Okay. We need to be able to say, "Hey, we are vulnerable. Our bodies are going to do what they need to do and do what they want to do, and if we're not on top of it, you may pay the price for it."
Thank you very much. Denise, Rick, thanks so much for sharing your story with us today. Dr. Bruce, Dr. Miller, Chaplain, thank you so much for being with us today. It's now my pleasure to turn the program back over to President and Chief Executive Officer of the Ohio Hospital Association, Mike Abrams. Mike?
Well, thank you, Jim, and to all of our panelists for being willing to share your very compelling story. That was so interesting. As we heard from our panel, the recognition of the signs of sepsis is important and does save lives. Community collaboration is a vital part of the OHA SOS campaign, and I'm proud to welcome our partner, Leading Age, represented by Beth Griebel, who will share their efforts on sepsis. Thank you.
Thank you. Good morning, and what a remarkable, touching story. Thank you, all of you, for sharing. Leading Age Ohio represents approximately 500 service providers in more than 150 cities and towns across Ohio. Although it's not an exhaustive list, our members include nursing facility, assisted living facilities, home health agencies, hospices, adult day centers, and affordable housing providers. Our member organizations employ more than 35,000 people who touch an estimated 400,000 lives annually. Together with the Ohio Hospital Association, we represent the entire continuum of care for seriously ill Ohioans. Sepsis is an issue that is not only central to our organization's commitment to safety and quality of care, but has also affected us on a personal level. In addition to our friends Denise and Rick, it has affected my colleagues and my family. Sepsis is indiscriminate, with the very young and the elderly among the most vulnerable. We know that more than 80% of sepsis cases originate not inside the hospital walls, but in places where Leading Age Ohio members care for Ohioans, in their homes and communities. Early identification and recognition of the signs and symptoms of sepsis greatly increase an individual's likelihood of survival and recovery, and early identification depends almost entirely on the public and professional awareness. Leading Age Ohio has partnered with its members and the Ohio Hospital Association in the goal to reduce sepsis mortality by 30% by December 2018. Already, this campaign has resulted in a 13.4% reduction, but as Mr. Abrams said, we have much work to do. We will continue to work to promote professional education, training, and best practices to our member organizations to reduce risk and offer early interventions when treatment is most likely to be effective. Leading Age Ohio is proud to be part of this statewide effort to promote sepsis awareness and reduce incidence and mortality. Mr. Abrams, thank you for inviting us to join you today.
Thank you, Beth, for being willing to share the work of Leading Age Ohio on this important endeavor. Engagement is an important component of achieving sepsis reduction. In our work for the Sepsis Initiative, OHA has partnered with the National Sepsis Alliance and is advised by a local physician who is also a founding member and board member for the Sepsis Alliance. We're fortunate that our key national ally is based right here in Columbus. So please join me in welcoming Dr. Jim O'Brien, Chair of the Sepsis Alliance, who will share some insight on the national efforts on sepsis.
Thank you, Mike. So it's a pleasure representing Sepsis Alliance here at this event today, and I want to thank OHA for hosting such a wonderful event as Sepsis Awareness Month comes to a close. Sepsis Alliance is the largest advocacy group for sepsis in the United States. It was founded in 2007 by Carl Flatley. Carl unfortunately lost his daughter Erin to sepsis, lost her needlessly, because as opposed to the story you heard of the excellent care that was provided from EMS all the way through to Fairfield Medical Center, that wasn't what Erin experienced 10 years ago. Therefore, Carl set forth to start an organization whose mission was to save lives and to reduce suffering by raising awareness of sepsis as a medical emergency. And the vision of Sepsis Alliance is that we will wind up creating a world in which no one winds up suffering as a result of sepsis. There's a great deal of work to be done. As you heard, we currently have an awareness of 58% in this country, but when Sepsis Alliance began, it was at 19%. And so we are very gratified by the improvements that have been made as a result of efforts. We're also very gratified in our partnership with OHA. We absolutely believe at Sepsis Alliance that this problem winds up being solved only by engaging all the stakeholders. And therefore, it's absolutely integral that we wind up having folks who are directly affected by sepsis partnering with people who are in healthcare and partnering with community resources in order that we can solve this problem. I'm particularly gratified by the approach that OHA is taking in engaging the continuum of care. Because as you heard, certainly engaging EMS and pre-hospital providers is very essential, but also in trying to address the morbidity that we're finding is more and more common for survivors of sepsis is very important as well. And so we need to think about how we continue to help those survivors to not just survive, but to thrive and to regain their previous function. I'm also very glad about the statewide initiative that has been going on that, as you've heard, has resulted in thousands of Ohioans survive who otherwise would have died in the past. Finally, I'm very proud to have participated in some of the regional outreach efforts, going out speaking to healthcare providers across the state to try and raise awareness about this disease and also to raise awareness about what is available to improve the outcomes for these patients today. Finally, I'll just offer that for me this has been a personal journey as well. Mother's Day of this year, my mother wound up suffering from sepsis. And thankfully, she wound up receiving care in one of OHA's hospitals. And as a result, wound up having a good outcome from the hospital and is now on the mend from recovering to her previous function. So again, I want to, on behalf of Sepsis Alliance, thank OHA for all the work they're doing, and also thank Denise and Rick for sharing their stories. Something that we find at Sepsis Alliance through our sharing of other stories is absolutely compelling and essential for us moving forward in solving this problem. Thank you.
Well, thanks, Dr. O'Brien and Beth, for being willing to come and offer your support. We are going to reach our 30% goal due in large part to the work that you're doing on this initiative. It's now our opportunity to turn to your questions.
At this time, we will open the event to questions from the audience. If you are joining us online, please submit your questions to sos@ohiohospitals.org. Once again, the email address is sos@ohiohospitals.org. For the first question, we'll turn it back over to Jim Giuliano.
Hi. So we do have a question, and the question is, what is OHA's initiative doing to advocate for sepsis awareness in Ohio? And I would like to speak on behalf of our organization. You know, over half of sepsis deaths could be prevented through early recognition and early appropriate intervention. And to that end, it's so important to educate not only healthcare providers, but also the public. And so what we are doing from an advocacy standpoint is that we are not only working with our member hospitals on clinical improvements, but we are also working with the entire continuum of care. This includes, as Mike mentioned, emergency medical service providers on the pre-hospital side, and also working with post-acute providers on the post-hospital side, such as nursing homes, assisted living, residential care facilities, daycare centers, corrections facilities, and the like, so that others can pick up on those early signs that Denise talked about early, when something just doesn't seem right, coupled with either a suspected or a confirmed infection. So this is some of the work that we are doing. If you'd like to learn more about the signs of sepsis in our campaign, we would encourage you to visit our website, which is located at ohiohospitals.org/sepsis. That's ohiohospitals, plural, .org/sepsis. The next question that has come in is a question that I will give to Denise. And it says, what would you say was the biggest sign that you needed to get your husband to a hospital?
I think the confusion, because I knew there was something neurologically wrong. I mean, any of us can, you know, bump something, pull something, and have pain. So the pain was significant to me, but the confusion was what really made me think that there's a severe problem here.
So that was your
That was
the
what really hit
tip-off
my
sign.
gut. I mean, I was upset about the pain,
Sure.
but coupled with the confusion, I knew that, I mean, that just was a sign that there was a significant problem. You know, when he just wasn't making sense, and I could not redirect him. So I knew that there was something neurologically going on, and that was, you know, a sign that I didn't know if it was related to his cardiovascular system, his neuro system. I didn't know. I just knew that was not a good sign. There
And
was
that's what
something
compelled
wrong.
you to act. Thank you, Denise. Our next question is, what are hospitals doing to increase the chances of patients with sepsis do not die? Dr. Bruce, maybe I'll turn that one over to you.
Yeah, I think the team effort that we spoke with, from early recognition, pre-EMS, emergency room, and then transitioning based on your level of acuity to a place in the hospital that can carry forth some form of a sepsis protocol, a predefined set of interventions that have evidence behind them that if you do these in a timely fashion, you'll give a patient the best chance to survive. So most hospitals have adopted some form of a protocol like that. These are all things we've known for a while that help. But this is putting them into a streamlined process that will not only make it easy for all the staff, regardless of your level of understanding of sepsis, even as a healthcare provider, to get these done in a timely fashion, but also so that each place has a quality improvement. So we're continually, including at FMC, through our team that came today, still continuing to work on improving our own process, being better at doing those interventions as well as recognizing.
Yes, and that really speaks to the whole mantra of it takes a village, but it also speaks to the fact that there's great leadership support for this work as well, and accountability. So thank you very much. This question is for Rick, and the question states, Rick, what do you think was the biggest reason that you survived?
I would say my wife, first and foremost, recognizing that there was something wrong and acting upon it. And then I guess I'll pat myself on the back here a little bit, besides all the staff helping me out. But I mean, my will to actually survive. Like I said before, I'm pretty stubborn about a lot of things, and I'm always going forward no matter what's going on.
That constitution, yes.
Yeah.
Well, thank you.
If I can pat him on the back, I think that needs to really be described for what Rick went through. Survival of sepsis, but as Dr. O'Brien mentioned, the morbidity, the difficulty in returning to a normal quality of life, and we can give you all the tools, but it's only you as a patient that can get yourself back there through continued therapy and continued pushing yourself every day. And the reason Rick's here is as much his own willpower to be a survivor as it is for the interventions that we've done.
Well, and that's stuff like at the hospital. They're saying, "Are you sure you want to do this? Do you think you can do this?"
Yeah.
And I'm saying, "Just get out of my way. I'm going to do it." And they were shocked. Number one, and I was like, "This is what I do."
Yep.
Yes, yes. You know, our last question that we have submitted to us is a question that says, what information is most important to have when a patient goes to an emergency department suspecting that he or she might have sepsis? And Dr. Miller, I'll turn that one over to you, being an emergency department physician. Your perspective.
So oftentimes, you just have to listen to the patient and to the family, and you have to look at the big picture, the vital signs, the history. You have to do a thorough exam, and it's about looking at those pieces and being able to put that diagnosis in your differential. Like, this could be a possibility. We need to act on this and, get this put together as quickly as possible for the patient's benefit. And most of the time, if you listen and if you just look and you use your knowledge, then, it's not hard to do. You just have to be able to recognize the signs and symptoms of sepsis to be able to help somebody. So.
Thank you. Thank you. One other question that has come in through email is asking about the family perspective and how do you address the despair that patients might feel when they're going through this journey. Denise, you talked a lot about your feelings. Chaplain, I'll turn that one over to you from a despair standpoint.
Indeed, that's a natural reaction, and maybe as I've been listening once again to the account from Rick and Denise's perspective, that's where we need to be transparent and just recognize that we are going to have those moments that are unseen, uncontrolled, and really out of our hands. So that's where we need to really reach out and rely upon our staff, our support of our family, but ultimately to say that there's something still that brings hope. And whether that's faith, whether that's a will to live, ultimately it's all about seeing the bigger picture and seeing that despair is really part of the cycle of life. And we have to really embrace that moment and really hope and pray in whatever fashion we do that we can be seen through that time to improved health.
Thank you. Thank you very much. We appreciate that.
And we did have an additional question come in. What is the criteria for determining a diagnosis of sepsis?
Dr. Bruce, perhaps you'd like to address that question.
I think from, how can I say it the right way? Basically, sepsis being, as we've said here, so from a community standpoint, is any signs of infection coupled with alterations or other end organ manifestations that are changing. And so again, we talk about vital signs that we often use. We talk about mental status changes, which is this. It's something that just says, listen, this isn't just the fever that I'm having with a sinus infection. It's that there are other parts of my body that appear to be shutting down. And from a community perspective, honestly, that's a much better explanation probably than the ones that we use as a criteria-based diagnosis within the hospital, because those are vital sign-based and they're not quite as available from an early recognition standpoint.
Yes.
And this question is directed towards Dr. Miller. What would you say was the most important piece to obtaining a streamlined continuity of care between the ED to the ICU?
Relaying the information to the on-call critical care physician so that they can be aware of the patient and know that the critical nature, so they can be prepared for phone calls, or if they're, oftentimes when you are administering medicine, such as medicine to keep their blood pressure high, antibiotics, lots of fluids. Multiple things can happen, so you need to be able to relay the information to them as soon as possible so they can be aware of the patient and know that something, a complication from those medicines may happen, or, further intervention may need to occur, and so that they can be aware of the patient earlier than later.
Thank you. Ladies and gentlemen, this concludes our Q&A session of the program, but if you have further questions, please feel free to email them to sos@ohiohospitals.org. Thank you. And now I'd like to welcome back Mike Abrams.
Well, I want to thank all of our participants and presenters, as well as all the attendees, for your attention this morning. Again, our website, ohiohospitals.org/SOS. And this is a resource for you to learn about the signs of sepsis, to identify potential sepsis cases early. We truly appreciate this opportunity of collaboration and partnership and look forward to working with all of you. Together, we can reduce sepsis mortality and ensure a healthy Ohio. Thank you.